Thank you for listening to this PYA webinar recast. PYA is pleased to offer this alternative way to access our thought leadership. This is a recording of a previously delivered webinar. The information is accurate as of the date of the original event. The video recording, slides, and associated material for this and all PYA webinars are available on our website at pyapc.com. This podcast is for educational purposes only. It is not intended to be used as legal advice or an official opinion.
Good morning, everyone. Welcome to today's episode of PYA's Healthcare Regulatory Roundup webinar series. Today's topic is preparing for OBBBA impacts, Medicare DSH and 340B updates. PYA is happy to present today's webinar on this important topic. I would like to introduce our presenters, Sarah Bowman, Katie Baker, and Ramsey Fadile.
Jennifer, thanks so much. I'm Sarah Bowman. I'm a principal with PYA in our Revenue and Compliance Advisory area, and I'm joined today by my colleagues Katie Baker out of our Atlanta office and Ramsey Fadile located here in Knoxville along with me. And we're excited and happy to be with you today to talk about this important topic, Medicare DSH and 340B in light of the One Big Beautiful Bill Act changes. So Ramsey, I'm going to pass it to you to kick us off.
We'll start by talking through some of the specifics of the new Medicaid community engagement requirements that come from the One Big Beautiful Bill Act. And then we'll get into how this could impact hospitals through their DSH percentage. We'll then provide strategies for accurately identifying and reporting all DSH eligible days. And finally, we'll summarize some recent 340B policy and regulatory updates. So to start, let's discuss the Medicaid community engagement requirements. Effective January 1st of next year, adults aged 19 to 64 who are enrolled in Medicaid through the Affordable Care Act Medicaid expansion or equivalent coverage must complete at least 80 hours per month of paid employment, job training, education, and/or community service unless a specific exception is met. At enrollment, a state must verify that the individual met this requirement or met the terms of the exception during the month prior to application. Afterwards, a beneficiary's compliance must be verified every 6 months. In addition to this, the time period for retroactive Medicaid coverage will be reduced from 3 months to 1 month. Now, a comprehensive interim final rule about this will be published by June 1st of this year, and shortly thereafter, states will be required to inform their beneficiaries of the new requirements. A state can request an extension for this, but the request will not be granted unless the state demonstrates it is making a good faith effort to meet the requirements. So what does this all mean for hospitals? Well, there are several potential impacts from the increased Medicaid eligibility requirements. The first is that we could see procedural disenrollments from the Medicaid program, which could lower Medicaid patient volume at hospitals and increase self-pay and uninsured volume. This in turn could lower Medicare DSH percentage at some hospitals, and it could potentially result in the loss of qualification of DSH add-on payments or the 340B drug program for some hospitals. So next, let's talk about Medicare DSH. So Medicare DSH, the DSH in Medicare DSH stands for Disproportionate Share Hospital. And Medicare makes additional payments to hospitals that serve a disproportionate number of low-income patients. And the idea is that these additional payments would offset the higher costs that are associated with providing care to these patients. Now, one thing to point out is that Medicare DSH is different than Medicaid DSH, even though Medicare uses Medicaid eligible days to determine eligibility for Medicare DSH. And we'll get more into that in a little bit. Now, there are two different types of Medicare DSH. The first is empirically justified or traditional DSH, and that's driven by a hospital's Medicaid eligible days and their Medicare supplemental security income or SSI percentage. The other form of DSH is uncompensated care or UCC DSH, and that's driven by a hospital's cost of its uncompensated care from charity and bad debt. Now, for those of you who are longtime cost report experts, you'll remember that years ago there was only one kind of Medicare DSH, and that was the empirically justified or traditional DSH. So today we're going to spend most of our time talking about that traditional or empirically justified DSH, since that's the one that's most likely to be impacted by the new Medicaid community engagement requirements, and since that is the type of DSH that affects qualification for the 340B drug program. For the purposes of our discussion today, whenever you hear me refer to just DSH, I'm referring to empirically justified or traditional DSH. Okay, so now we'll go into some of the specifics of how the DSH percentage is calculated. So the entire DSH formula can be somewhat complex, but to help simplify it, we'll discuss the two main drivers of the DSH percentage, which are relatively simple to understand. And there's only one driver that a hospital can control. So the two main drivers are the Medicaid ratio, or the Medicaid fraction, and the Medicare supplemental security income, or SSI percentage. So the Medicaid ratio is the percentage of total patient days that are attributable to patients who are eligible for Medicaid but not entitled to Medicare Part A coverage. In other words, these are your Medicaid non-Medicare days divided by your total patient days. The second driver is the Medicare Supplemental Security Income, or SSI percentage, and that is the percentage of total Medicare patient days that are attributable to patients who are entitled to both Medicare Part A coverage and Supplemental Security Income, or SSI. For those of you who may not know, SSI is a federal income assistance program that is administered by the Social Security Administration to adults and children with a disability or blindness and limited income, and to adults 65 plus without disabilities who meet certain financial qualifications. So the SSI percentage for each hospital is published by CMS based on CMS's own records. So these two drivers, the Medicaid ratio and the SSI percentage, make up what's known as the disproportionate patient percentage, or the DPP. And we'll be talking a lot about the DPP later today. So how is the Medicare DSH percentage calculated? Well, the DPP that we just discussed must be 15% or greater in order for a hospital to qualify for Medicare DSH. So let's walk through an example. So if a hospital has 1,000 Medicaid non-Medicare days and they have 5,000 total patient days, their Medicaid ratio is 1,000 divided by 5,000, or 20%. If that same hospital has 200 Medicare Supplemental Security Income, or SSI days, out of 2,000 total Medicare Part A days, that means their Medicare SSI percentage is 10%. So for this example, the hospital's DPP, or disproportionate patient percentage, is 30%, which is just the sum of the Medicaid ratio and the Medicare SSI percentage. Now, in this example, since this hospital's DPP is greater than 15%, the hospital qualifies for Medicare DSH, both empirically justified DSH and uncompensated care DSH. Now, it is important to note that the DPP is not the same as the final DSH percentage. The DPP is only used as the qualification threshold for DSH. Now remember I said that the DSH formula is somewhat complex. Well, here's a visual representation of the operating portion of the empirically justified DSH calculation. So once a hospital qualifies for Medicare DSH with a DPP of 15% or greater, then the formulas that you see on the screen in the far right column, those will apply. And as you can see, there are different formulas for different types of hospitals. So urban hospitals with a certain number of beds have a certain formula that applies. And then urban hospitals with more beds have a different one. Same thing for rural referral centers or just rural hospitals in general. There's also a separate capital DSH payment that has its own formula that is not on the screen here, and we'll go over that briefly on another slide. So again, while the specifics of the formula are complex, the general idea is relatively simple. The higher a hospital's Medicaid ratio and SSI percentage, which together make up the DPP, the higher a hospital's DSH percentage. Okay, so that was a lot of math, and the question is, why does it all matter? Well, there are two main reasons. First of all, DSH hospitals receive an add-on payment on each Medicare traditional inpatient claim. So the higher a hospital's DSH percentage, the higher its add-on payment on each inpatient claim. Secondly, the DSH percentage determines qualification for the 340B drug program for most nonprofit hospitals. And we'll go over that more in a little bit. So let's talk more about the DSH add-on payment on each Medicare traditional inpatient claim. So those complex formulas from a couple slides ago are used to calculate the DSH percentage that is reported on worksheet E Part A, line 33 of the Medicare cost report. But of course, it's not that simple, because you have to multiply that percentage from E Part A, line 33 by 25% to get the final add-on percentage for each Medicare traditional inpatient claim. So let's go through an example. If a hospital has a DSH percentage of 40% on worksheet E Part A, line 33 of the cost report, we have to multiply that 40% by 25% to get the final add-on payment of 10% on each claim. So if a hospital's claim payment before DSH was $1,000, then we take that 10% and get $100, which is the DSH add-on, for a total claim payment of $1,100. Now that example we went through was for the operating portion of the DSH payment. And as I mentioned earlier, there is a capital DSH add-on payment as well. It's usually a smaller payment, and it's calculated based on the formula that you see in green there, which is a 2.7 raised to the power. And as you see there, there's DPP again. And that's what we were discussing earlier. The DPP is involved in the formula. So again, more complicated formulas, but to keep it simple, the higher a hospital's Medicaid eligible days, the higher its DSH percentage, and the higher its add-on payment on each claim will be. So we've seen how the DSH percentage is important because it results in increased reimbursement in the form of an add-on payment to each Medicare traditional inpatient claim. So how can we make sure that we are accurately identifying and reporting all Medicaid eligible days for our DSH percentage? Well, first, let's remember the two main components that impact a DSH percentage. The first is the Medicare SSI percentage, which is published by CMS based on their own internal records, and it's also published on a delay. So this item is outside of the hospital's control. But the other item is within the hospital's control, which is accurately identifying and reporting all Medicaid eligible days. So we'll go through some strategies on how hospitals can do that. The first strategy is to make sure that you're using the most up-to-date Medicaid eligibility data. Now, as some of you may know, the cost report is due 5 months after your hospital's fiscal year end. Now, for some states, the final Medicaid eligibility results are not ready for sometimes until after the cost report is due. But in many cases, the longer you wait, the more complete and accurate results are available, and the more patients that will come back as eligible when you submit them to the state. So if you're a hospital that is close to a qualification threshold, either for the DSH add-on payment itself or for the 340B program, it would be beneficial for you to wait as long as feasible to run those Medicaid eligibility lookups so that you can get complete and accurate results. It's very important to note that a hospital will become ineligible for the 340B program on the day that it files a cost report with a DSH percentage that is below the threshold. And we'll discuss the thresholds briefly in a few slides. The next strategy is to use quality demographic data for the Medicaid eligibility lookups. So in order to determine Medicaid eligibility, a hospital will need to submit its inpatient roster to the state that the patient was from. So the demographic details are very important. Things such as the Social Security number, the Medicaid ID, date of birth, all of these items should be as complete and accurate as possible in order to make sure that the hospital is getting accurate eligibility results. If any of that information is missing, it could reduce the chance of receiving a match when the Medicaid eligibility checks are performed, which could result in a lower Medicaid ratio and a lower DSH percentage. The next strategy is to check the eligibility of any out-of-state patients. So let's say you're a hospital in Florida and a patient with Georgia Medicaid coverage comes to your hospital. Now, Georgia Medicaid may not pay for treatment outside of Georgia. So the Florida hospital may classify that patient as self-pay because Medicaid is not paying. But for Medicaid DSH purposes, it's very important to note that it only matters if a patient is eligible for Medicaid in a state, not whether Medicaid actually paid for the claim. So again, if a patient is eligible for Medicaid in their home state, the hospital can claim that patient as eligible for purposes of the DSH calculation, regardless of payment. Now, the next strategy is to evaluate obstetrics and psychiatric departments. Psych departments are a particularly interesting case because they can be set up as a distinct part unit with their own CMS certification number, or they can simply function as another department of the acute hospital. Now, if a psych department is set up as its own distinct subprovider with its own CMS certification number, its claims will be paid by Medicare using a different payment system from the rest of the hospital. And importantly, the days from a distinct part psych unit are not included in the Medicaid ratio of the DSH calculation. So they're not included in the numerator, which is your Medicaid eligible days, and they're not included in the denominator, which is your total patient days. Now, given that psych units tend to have high Medicaid utilization, excluding the psych days from the Medicaid ratio could result in a lower DSH percentage. So if you're trying to determine what would make the most financial sense for your hospital, you should weigh any potential benefits that might come from setting up a distinct part psych unit against the potential downsides of a DSH percentage that could be lower. Now, this is particularly important if your hospital is close to the qualification thresholds for the DSH add-on payment itself or for the 340B program. Similar to psych departments, obstetrics departments are another area that should be considered because OB departments often generate losses, and some hospitals may consider closing them or consolidating them with another location within the health system. But similar to psych departments, OB departments tend to have high Medicaid utilization. And if a hospital is close to the qualification thresholds for DSH or 340B, the OB department could be the difference between qualifying and not qualifying. Okay, we have a few final strategies here. The first is to ensure accurate matching of newborns to mothers. So when you're performing those Medicaid eligibility lookups that we discussed earlier, newborns can be considered Medicaid eligible if their mother was eligible for Medicaid. So hospitals should make sure they have a good system to track and match newborns to their mothers so that the newborns can be made Medicaid eligible for the DSH calculation if their mothers are Medicaid eligible. And finally, we have marketing to the Medicaid population. Now, while this is generally not a preferred strategy, for hospitals that are close to qualification thresholds, it may be beneficial for them. There's one other item that I want to discuss, and that's related to SSI realignment. Now, if you remember, the Medicare SSI percentage is published by CMS based on their own internal records, and it's outside of the hospital's control. The data is also often published on a lag, and it uses the federal fiscal year of 9/30, which often does not align with a hospital's fiscal year. So for example, just earlier this month, CMS published the SSI percentages for hospitals for their federal fiscal year of 2024. So for fiscal year ending 9/30/24. So not only is this out of date, but it's also not aligned with most hospitals' fiscal year end. So to correct this, a hospital can actually go back and amend its old cost reports once the SSI data finally catches up, and they can also adjust the SSI percentage to account for the different fiscal year ends. Now, this could result in additional DSH add-on payments if the updated SSI percentage was higher than the one that was on the original filed cost report. But even if that is the case, it's important to note that this would not retroactively confer eligibility for the 340B drug program. So if the hospital did not qualify for 340B 2 years ago, and now that new SSIs are ready and they go back and they refile and now they do qualify based on the percentage, they can't go back and claim 340B drug discounts for those old years. Okay, so we've covered the first way that the DSH percentage impacts reimbursement, which was the add-on payment on each Medicare traditional inpatient claim. And we discussed strategies to accurately identify and report all Medicaid eligible days. So the last item I want to discuss related to DSH is the role that the DSH percentage plays in qualification for 340B drug program discounts. So different hospitals have different qualification requirements. DSH hospitals are your standard acute nonprofit hospitals, and they qualify with a DSH percentage that is greater than 11.75%. Again, the number that you're looking for here is on worksheet E Part A, line 33 of the Medicare cost report. Now, rural referral centers and sole community hospitals qualify for 340B at a lower threshold of greater than or equal to 8%, but it's important to note that they are subject to the orphan drug exclusion. And as we know, orphan drugs are typically more expensive than other drugs, so this is a very important distinction. Children's hospitals and freestanding cancer hospitals don't receive DSH payments, but they still must have a DSH percentage of greater than 11.75%, or a payer mix equivalent of that. And critical access hospitals don't receive DSH, and there are no DSH requirements to be eligible for 340B. But there are other requirements that are specific to cause for 340B eligibility that are not related to DSH. Well, now that we've started to talk about the 340B drug program, it would be a good time to pass it over to Sarah Bowman, who will discuss recent updates to regulations related to the 340B program.
Awesome. Thanks, Ramsey. So Ramsey's done a great job giving us a detailed look at how the DSH is impactful to healthcare organizations and specifically in helping covered entities qualify for 340B to begin with. I want to transition a little bit and talk about some key updates for this year for the 340 drug pricing program. So despite receiving immense scrutiny for really several years now, we have yet to see comprehensive legislative reform enacted to help sort of specify, give some structural answers to many of the pieces of the program that are challenging for covered entities that are somewhat ambiguous. So we have considerations related to HRSA's authority, manufacturer obligations to provide covered entities with those discounted prices on those 340B drugs. And then we have, ongoing contract pharmacy disputes and concerns related to data sharing, access to those 340B prices. The congressional attention overall related to the 340B program remains pretty high. So it's really, we're in a bit of an uncertain environment, but definitely one where we're seeing a lot of attention and a lot of impacts. So because of this, we really expect covered entities and recommend covered entities to start, if you're not already, preparing for impacts of the One Big Beautiful Bill Act, as Ramsey discussed, looking at your DSH calculations and how you're doing those today, and then preparing for some of these other impacts, which we'll discuss a bit further as it relates to the 340B program. So a couple of the things that Katie and I will cover are going to be, I'll say, small wins for the contract, for the covered entities participating in the 340B program. This is certainly one of them. So historically, covered entities would have to confirm eligibility through their Medicare cost report process of the parent site, as Ramsey mentioned, that 11.75% threshold or 8% for certain types of hospitals, and then follow HRSA's quarterly registration windows to add child sites to their 340B program. So those registration windows occur in January, April, July, and October. And so after adding a new child site during one of those registration windows, the first 15 days of those months that I mentioned, then the effective date for that child site, so the date at which the child site could start accessing those 340B drugs, would be the start of the following quarter. So a January child site registration would then receive access to discounted drugs effective April 1st, for example. So, but that presents a situation where between the timing of the filing of the Medicare cost report, those quarterly registration windows under HRSA, and then the effective date or start date, if you will, for access to the program, there were significant delays in the timing of accessing those drug discounts. So we saw this, we saw HRSA give some leeway to this process during the COVID public health emergency, which was very much welcomed by providers and allowed child sites to get access to 340B pricing prior to those cost report and registration processes. When that flexibility ended, we saw a number of covered entities challenge that in the courts. So there were, I believe, greater than 40 covered entities that brought forth challenges to that. So the ultimately the providers were successful. They were successful. The U.S. District Court ruled in favor in the case of Albany Med Health System, and that was just earlier this month. That was, I think, at the beginning of March. And so the U.S. District Court ruled that there is no statutory requirement to register outpatient child sites first to get access to the 340B drug pricing program. So that definitely creates additional opportunities for covered entities to recognize savings a bit earlier in their outpatient settings, minimizes delays in that timeline for the approval process and inclusion on the OPACE database, the OPA database. It is important to remember that while this is great and definitely a win, as I mentioned, to getting access to those discounted drugs earlier, it does not eliminate HRSA's role and responsibility to provide oversight of the compliance of the program. It is still important for covered entities to continue to meet existing compliance parameters. So patient eligibility, making sure that you're not incurring duplicate discounts, making sure that you have a good diversion prevention program so that patients that are not eligible for 340B drug discounts are not receiving those drugs. And then obviously continuing to maintain an audit-ready environment. These are all important pillars of a compliant 340B program. Those haven't changed as a result of this ruling. We also want to reiterate that registration should continue to occur and hospitals should continue to maintain accurate OPACE listings, but that is no longer a prerequisite for getting access to that 340B pricing. Just a note as we think about upcoming changes in the next couple of years, and this is separate from 340B, but we definitely feel it's worth mentioning. It's going to be interesting to see how these changes, along with the new requirements from the Consolidated Appropriations Act, unfold over the next 2 years. So the Consolidated Appropriations Act of 2026 requires that all off-campus provider-based locations complete the attestation process, which has historically been a voluntary process. It makes that process mandatory for off-campus locations, and also requires that they obtain a unique NPI number to be effective January 1 of 2028. So it'll be interesting to kind of see how that process intertwines with the 340B program. So we'll have to keep an eye out for that. Some would say that this next slide and what we're going to talk about related to the rebate model pilot program is also a win for providers. And while it definitely is a win in some regard, and that it is on hold for now, it's probably a little bit early for covered entities to fully celebrate, because we think that we'll continue to see more activity on this item in particular. So as a quick refresh, pharmaceutical manufacturers have been pushing for increased transparency for several years. They've argued that the 340B program has grown beyond its original intent, and that there are compliance issues, that there needs to be better oversight, better monitoring. So the rebate model is something that has been proposed in various forms from pharmaceutical companies, but this model in particular was proposed by HRSA. It was supposed to go into effect earlier this year, but has been blocked for now, but would require covered entity hospitals to initially purchase those drugs basically at their sticker price, so not getting any discount at the time of purchase, and then submit information regarding the dispensing of those medications within 45 days of dispense to receive a rebate after the fact. So essentially to receive those funds back, the difference between the sticker price that was paid and the 340B kind of corrected price, if you will, for those 340B eligible patients. That rebate process would occur electronically through the Beacon platform, and those rebates would need to occur within 10 days, the way that HRSA had outlined the program. So obviously the intent of the rebate model was to improve program integrity, reduce the opportunity for duplicate discounts to occur erroneously. HRSA had approved 8 manufacturers for participation. Interestingly enough, the manufacturer participation was voluntary, while the covered entity participation was mandatory. There was no way for covered entities to opt out, if you will, and included specific medications, 9 specific medications that are generally pretty high use. So it was slated to begin in January. It was ultimately blocked in February, due to failure to follow procedural requirements. That was essentially the ruling as we have it right now. So HHS is evaluating this program. They're evaluating how they can implement a program that is consistent with its statutory authority. So to do that, it is collecting data right now. It is going through an RFI process, a request for information process, to assess whether it should be implemented, and if so, how should this program be managed operationally. So it's seeking feedback from covered entities, responses to the RFI. They were previously set to be due March 19th, but that has been extended. Responses are now due April 20th. So you've got about a month left. As of yesterday afternoon, there had been 103 comments submitted to that RFI, but responses are definitely encouraged. So if this is something that you have thought about and talked about within your organization but have not yet responded, we definitely would encourage you to please do so. Make your thoughts known, make your feedback known. A lot of the concern that many have had around this program is just the financial impact of bearing the costs of those drugs up front and having to carry those costs until the rebate process can be completed, along with some of the administrative concerns with just operationalizing that, making sure that you've got the right staffing model and the right technology in place to be able to complete a rebate process like that for specific medications and manufacturers. So we'll definitely be interested and continue to watch on our end to see what happens next with the rebate model. And the next item is something that has unfolded, I would say, probably over the course of a number of years. So the Social Security Act requires HHS to periodically conduct surveys of hospital acquisition costs for covered outpatient drugs. This requirement was reinforced in the spring of last year, in April of 2025, when President Trump issued an executive order to require the secretary to publish a plan to conduct a survey. And so this is the survey. It's important to note that previously there have been attempts to adjust drug pricing, specifically drugs acquired under the 340B program. So we saw this occur back in 2018 through September of 2022. We saw Medicare reduce reimbursement for separately payable outpatient drugs, and that was challenged for a number of years in the courts. But ultimately, providers came out ahead on that ruling because ultimately the courts ruled that CMS had failed to conduct a survey to understand drug pricing. So this survey is really important for a number of reasons as we look back across kind of the history of drug pricing and reimbursement. So this plan was announced in the Outpatient Prospective Payment System final rule for this year, 2026, and they are calling this the OPS Drug Acquisition Cost Survey, which totally rolls right off the tongue. ODAX survey. I don't know if we're calling it ODAX, but that's the acronym. And it is requesting information for each separately payable outpatient drug acquired by all hospitals that are paid under OPS. So if you think about that for a minute, the number of drugs that are in your formulary as a healthcare provider, as a hospital, and then all of the hospitals kind of across the country that receive payment under OPS, that's a big ask. That is a large volume of information. CMS has said that they are going to use this information for policy making, beginning with the 2027 proposed rule. So beginning with what could happen as soon as next year. That proposed rule is expected later this summer, but they have already said that they intend to conduct this survey every 4 years. So right now, it doesn't appear that this is going to be a once and done. It appears that this is something that's going to continue. Hospitals, it's a bit up in the air as to whether or not that the survey is a mandatory survey for hospitals. So the survey process itself is required to be conducted, but hospitals that are reimbursed under OPS have to decide and are encouraged to work with legal counsel to evaluate whether or not they choose to respond to this survey. If they're going to respond, many of you may have already responded. Survey responses are due at the end of this month. So we're closing in on that due date very quickly now. The data collection efforts with this associated with this survey are pretty steep. The responses are to be provided at the 11-digit NDC level. And then respondents have to report units and net costs separately, whether they're looking at 340B acquired drugs or non-340B acquired drugs. And those responses are going to be used to potentially reduce reimbursement or help set reimbursement rates for hospitals for separately payable drugs. Particularly, we expect to see changes, as I mentioned, on 340B acquired drugs. So while, again, this survey is statutorily mandated, it has been said that the previous U.S. Supreme Court ruled that this payment cut burden will only be met if the survey results in a statistically significant estimate of drug costs. So we've got some providers that are concerned about what may happen if they don't respond, and some providers that are electing not to respond. So it's a bit of a mixed bag in terms of what we are hearing from our clients. But Katie, I'm going to transition to you to hear, so that our attendees can hear just a little bit more about this survey and what they can expect if they elect not to respond.
Absolutely. Thanks, Sarah. So as Sarah mentioned, while the survey itself is statutorily mandated for CMS to issue, the response is at the discretion of the covered entity. Again, in correspondence with legal counsel, recommend reaching out to them and having that conversation. However, it is not required to respond. So again, hospitals are thinking through whether or not that's the right option. CMS is considering what they've listed as, quote, reasonable assumptions in the event that a hospital does not respond, which to Sarah's point includes how those assumptions might be reflected in a potential future payment rate down the road. Sarah also mentioned the data lift required with the responses. There are some concerns as well around the clarity of the instructions for data submission. So it's, number one, administratively burdensome to gather a lot of this information at the 11-digit NDC and net cost level. There are also some requirements in there to exclude, purchases intended for inpatient use as requested. For some of our hospitals, these are huge amounts of drugs, huge amounts of dollars that are not always easily separated in this way. And so there are some questions around how to make sure that those inpatient purchases are excluded while still making sure that they're including everything that's being asked from a survey response perspective. The final bullet here is just another consideration for hospitals to make, which is that it does require an attestation to the truth, accuracy, and completeness of the data that's submitted. Very similar, again, for covered entities that are attesting for 340B reasons when entering information to the OPACE database. You're acknowledging that, that attestation makes sure that you've completed all of the different requirements, that you're saying that the information you've provided is as accurate as you know it to be at the time that you've submitted it. That same attestation is required for the survey responses. And so knowing that there are some concerns around clarity, lack of instruction, potential administrative burden, some hospitals are also considering whether responding is appropriate given the fact that they are asked to attest to the accuracy of this information when there is a little bit of confusion about what's required there. So again, just something for hospitals to think about, the requirement to respond, the lack of requirement to respond, the deadline is impending. And so making sure that we're thinking through whether or not that response is going to be included would be by the end of the month. And then while we're talking through some of the key 340B updates, there are also a lot of legislative actions that have been happening at the state level. We've seen a lot of state involvement over the past year or two, which is a little bit different than what we've seen in the past. Historically, states haven't been as involved in sort of management and ownership over the 340B program in their individual state. In 2025, there were actually 19 states that enacted 22 bills related to the 340B program specifically. And as of now, there are at least 13 states considering actions in 2026, knowing that there will likely be many more, especially as we think through rebate model, survey participation, and the other matters that we've talked about today. So what are some of these legislative actions doing? One of the big buckets is establishing pharmacy protection, so specific to contract pharmacies within the 340B program. 2 different states, Maine and Oklahoma, now require that 340B contracted pharmacies receive the same reimbursement as non-participating pharmacies. There's been some analysis and movement in this space as well, looking at reimbursement levels for, again, contracted pharmacies under the 340B program versus non, and evaluating whether or not that reimbursement has parity. And so thinking through those pieces right now, other states may be following suit, particularly in trying to protect some of those dispensations that hospitals are having covered under their contract pharmacy relationships and outside of the 4 walls of the hospital. Arizona has also recently passed a bill that prohibits third parties, so in that case, manufacturers, vendors, et cetera, from imposing additional fees, assessments, or clawbacks on 340B contracted pharmacies specifically. This creates an environment where third parties cannot place different fees, different assessments, or requirements on 340B contracted pharmacies when it comes to, again, the 340B program. Rhode Island has also banned pharmacy network exclusion based on 340B participation, again, in an effort to protect some of those 340B contracted pharmacies, meaning that they are not allowed to use 340B participation as the only criteria for selecting whether a pharmacy falls in or out of network for a patient or for a plan. In 2026, so this year, there are some introduced bills as well that include references to preserving the patient's choice. So patient choice to fill their medications at either a 340B contracted pharmacy or even directly from the 340B covered entity. So that's something to think through as well. Oftentimes, when we think of the 340B program, the patients don't always know whether or not their prescription is being filled at a 340B contract pharmacy because so much of that is done in the split billing software and virtual inventory components. But this does mean that patients are allowed to choose and fill medications at the pharmacy of their choice or potentially from the covered entity directly. It also requires manufacturers not to limit their shipments of medications to 340B contracted pharmacies and covered entities. There's been a lot on the manufacturer side, a lot of movement there, asking for additional data pulls in line with 340B participation, asking for detailed dispensation level information before sending shipments or before making those decisions to work with 340B contracted pharmacies. And so a lot of this state legislation is in an effort to minimize that. So essentially to create an environment where 340B contracted pharmacies are not treated or paid differently than non-340B contracted pharmacies. So more to come in this space, but a little bit assuring to know that states are seeing the importance of the program and making some headway there and not just relying on federal guidance and HRSA guidance coming out. Another key reason for some of the bills that are being passed at the state level is prohibiting, again, claims data requirements to receive rebates. So I alluded to that on the last slide, but oftentimes some manufacturers are requiring claims data or other pieces of information from 340B entities that are not requested from non-340B contracted pharmacies. So to demonstrate program compliance, 340B pharmacies are required to report certain cost and pricing data to CMS, who then sends this information on to manufacturers. And again, as I mentioned, a lot of these manufacturers are now requiring that those 340B covered entities report that claims data before they're providing that drug pricing discount. This kind of also feeds off of what Sarah was mentioning about the rebate model, where in that system, you would be required, again, to provide purchasing information before receiving that rebate or discount on the back end instead of the front end, as entities do today. In New Mexico and South Dakota, there are some supply chain entities that are no longer allowed to require 340B claims or utilization data before providing reimbursement. So some states have already made some traction here. And there are similar bills related to this exact same stipulation in at least 11 states so far this year. So I think there are a couple of states that are sort of taking the lead and pioneering some of these efforts, but it does seem like a lot of other states are sort of following suit. So keep an eye on some state legislature information, state that you're in or states nearby that your state might be replicating as far as passing bills or introducing bills at the state level. This is a way in the interim while we wait for additional guidance and some of these other program decisions to be made to alleviate some of the pressures on 340B contracted pharmacies and entities. So with that, I'm going to turn it back over to Jennifer, who's going to close us out.
Thanks to our presenters, Sarah, Katie, and Ramsey. The slides and recordings for every episode of PYA's Healthcare Regulatory Roundup series are available in the Thought Leadership section of PYA's website, pyapc.com. While at our website, you may register for other PYA webinars and learn more about the full range of services offered by PYA. On behalf of PYA, thank you for joining us. Have a great rest of your day.
Thank you for listening to this PYA webinar recast. The video recording, slides, and associated material for this and all PYA webinars are available on our website. If you have any questions or if we can help, please contact us at pyapc.com. Thank you again for joining us and have a great rest of your day.